Next, a quick review of the cerebellum. We'll do some of the cerebellar anatomy and then some of the most common clinical syndromes. All right, so again, as we go through the neuroaxis here, you'll notice that in yellow we have all of the conditions that involve lower motor neurons, and above that we have conditions that involve upper motor neurons, but I put asterisks by the cerebellum and the basal ganglia because these patients have difficulty with movement, but it isn't because of weakness. And so the cerebellum does not contain upper motor neurons. It talks to other upper motor neurons, and that's why when we have a lesion in the cerebellum, those upper motor neurons are not coordinated well, and so there's ataxia, but we don't have weakness. Likewise, when we talk about basal ganglia disorders, the basal ganglia talks to upper motor neurons, but they are not a source of upper motor neurons themselves. So patients do not have weakness or upper motor neuron findings with either cerebellar lesions or basal ganglia lesions. All right, so on a sagittal section, we can see nicely here the cerebellum, the anterior lobe and primary fissure, and then the posterior lobe of the cerebellum. It's kind of hard to see the flocculonodular lobe, but it would kind of be in this location. We need to do some dissecting here to show that to you. And so here's kind of a nice overview of how the cerebellum works. All right, and so the cerebellum acts as a comparator. It compares intended movement with actual movement and is always giving the brain real-time feedback about the accuracy of movement. All right, so how do we understand this? Well, if we start here with the neurons that contribute to the cortical spinal tract. And so, of course, this is our most commonly discussed upper motor neuron pathway, right, which travels through the subcortical white matter, brainstem, crosses at the junction of the medulla and spinal cord, talks to lower motor neurons here, anterior horn cells, to move muscles. All right, but anytime you move a muscle, a parallel pathway is activated, which we see right here. And this is the corticopontocerebellar tract. It's going from the cortex to pontine nuclei, as the name indicates, in the pons. And then it crosses over in the middle cerebellar peduncle and feeds into the cerebellar cortex. And here we can see Purkinje cells in the cerebellar cortex. All right, so the function of this pathway then is to tell the cerebellum about the intended movement. The program for the intended movement is received there. All right, but as you're actually moving these muscles, all right, muscle spindles and Golgi tendons are activated, and this information then becomes the spinocerebellar pathways or tracts. 3 of the 4 go through the inferior cerebellar peduncle here, again to inform the cerebellum now of, how are the arms and legs doing? Did they carry out the movement accurately? And so it compares that information, the intended movement with the actual movement, and then a corrective feedback pathway goes back through the superior cerebellar peduncle up to the motor cortex, and so that always in real time then the motor cortex can provide very precise motor movement because it's getting that feedback from the cerebellum. Okay, on its way up to the cerebellum, the most important thalamic nucleus, as I'll list later, is the ventral lateral thalamic nucleus. Okay, so we have these 3 cerebellar peduncles. Now drawn here but not labeled are deep cerebellar nuclei. So I'll show you another picture of that, but basically anything going in or out of the cerebellum needs to relay through these deep cerebellar nuclei. All right, so this is a drawing which shows pretty much the same thing, except now we have the deep cerebellar nuclei named: dentate, globose, emboliform, and vestigial. Dogs eat good food is the way to remember those. These are actually 2 reversed around. I think the only ones really I would concentrate on knowing are the dentate and the vestigial in terms of function. Okay, and one other thing this drawing shows is that as this output goes back to the motor cortex through the VL of the thalamus, the red nucleus is also stimulated here, and we have an upper motor neuron pathway from the red nucleus called the rubrospinal tract that would also be influenced then by the cerebellum. All right, so I really don't think boards are going to show you a slide like this. At least I would be surprised, to have you identify the inferior olivary nucleus. But I think it is worthwhile knowing that when we talk about input to the cerebellum, that the input from the inferior olivary nucleus, which is a huge nucleus, has a very powerful effect on the cerebellum here through the inferior cerebellar peduncle, that these are called climbing fibers. Whereas everything else that goes into the cerebellum, whether it's spinocerebellar tract, or here are vestibular nuclei, which also communicate with the cerebellum, everything else that goes into the cerebellum we call mossy fibers. And maybe it is worthwhile just knowing that the importance of this input from the inferior olivary nucleus to the cerebellum, and that we name those differently, climbing fibers. Now, input to the cerebellum, and this is an overview, and so I'm just presenting what I think would be the high points. Okay, so there are 4 spinocerebellar tracts, 2 for the lower extremities, the dorsal and ventral spinocerebellar tract, 2 for the upper extremities. I think I would focus on the ones for the lower extremities, so this is below T6. You can see that these pathways originate either from muscle spindles or Golgi tendon organs. Probably not important to remember which is which. These are fast fibers, so either 1A or 1B, but I wouldn't spend time trying to remember that. In terms of the relay nuclei, I think there's only one to know by name, and that is Clark's nucleus, which we pointed out in the spinal cord. So remember, this becomes the dorsal spinocerebellar tract. And you should know that all of these spinocerebellar pathways go through the inferior cerebellar peduncle, except for the ventral spinocerebellar tract, which is a very strange pathway. It actually crosses twice and gets into the cerebellum through the superior cerebellar peduncle. And actually, I forgot to point that out, so let's come back here to this diagram. So here are 3 of the 4 spinocerebellar tracts going through the inferior cerebellar peduncle. Okay, but the ventral spinocerebellar tract actually crosses in the spinal cord, crosses again in the superior cerebellar peduncle, and so it really ends up at the same location, but it crosses twice. So that is the ventral spinocerebellar tract. And so this information we call unconscious proprioception to distinguish it from posterior column medial lemniscal afferent information, which is conscious proprioception. So in other words, the posterior columns, medial lemniscus, this is when you are aware my finger is now moving up or down. All right. The spinocerebellar tracts is not involved with anything that you are consciously aware of. It provides vitally important information relayed to the motor cortex to help regulate movement, but it is not telling you where your limbs are in space in a conscious sense. All right, so I'm just going to focus on 2 of the deep cerebellar nuclei. Here's the vestigial nucleus, and we can see that the vestigial nucleus communicates here with the vermis, the midline portion of the cerebellum, and the flocculonodular lobe. Okay, and we have the vestibular nuclei, which communicate with the cerebellum, and the vestigial nucleus communicates back with the vestibular nuclei. Okay, and so why do we say that a lesion of the vermis, the midline, gives the patient truncal midline ataxia? Well, we can see that the output of the vestigial nucleus and the flocculonodular lobe, the vermis and the flocculonodular lobe via the vestigial nucleus communicates with these nuclei in the medulla, the vestibular nuclei, the reticular formation, and that we have upper motor neuron pathways that originate from these nuclei, the vestibulospinal tract, the reticulospinal tract, and these upper motor neuron pathways control truncal midline musculature. All right, so that's why a lesion of the vermis or the vestigial nuclei will result in a truncal midline wide-based gait kind of ataxia. Okay. Also, you want to associate the vestigial nuclei with the flocculonodular lobe, which via communication with the vestibular nuclei is very important for control of eye movements. And so we'll see that a lesion here will also result in nystagmus and eye movement abnormalities. Okay, I'm going to skip over the emboliform and globose because I think those are less important. But the dentate nucleus is by far the largest deep cerebellar nuclei, and we can see this is the one that provides the major output here via the thalamus, VL of the thalamus, to the contralateral motor cortex. So if we have a lesion here of the dentate nucleus, then the opposite motor cortex is deprived of that important output, to inform it how it's doing. And since one side of the brain controls the opposite side of the body, a lesion of the dentate nucleus on one side results in a rather coarse ipsilateral ataxia and usually a tremor. All right, so in terms of lobes, we have an anterior lobe and vermis. Much of the anterior lobe is made up of the vermis, and this is called the spinocerebellum. And so a lesion here, we have again a truncal midline gait ataxia. The posterior lobe and lateral hemisphere is much larger, and so this is the portion of the cerebellum that communicates with the motor cortex, so it's sometimes called the cerebrocerebellum. And so the rule of thumb is the further out lateral you get in the cerebellum, the more lateral the ataxia will be. So a lesion here will result in significant distal ataxia. So the patient will be very clumsy, for example, using their hands. A finger to nose test will be very ataxic. And then we have the flocculonodular lobe, otherwise known as the vestibulocerebellum. So a lesion here, and remember the vestigial nucleus is involved in this, will result in a lot of nystagmus, eye movement problems, frequently vertigo, and kind of overlapping here with the anterior lobe, we'll have a gait ataxia. Okay, so here's a picture showing you the anterior lobe, and again, notice how much of the vermis makes up the anterior lobe, posterior lobe, and the flocculonodular lobe. Okay, so again, I'll just repeat what I've already said here, that the vermis and the flocculonodular lobe, we have communication between the Purkinje cells, the vestibular nucleus, and these upper motor neuron pathways that control truncal midline musculature, reticulospinal and vestibulospinal. And also how important the vestibular flocculonodular lobe here acts anatomically close to the vermis, and so we get a midline ataxia. The paravermis, a little more lateral located, and so you get maybe a little more proximal muscle problem with coordination. I'm going to skip over that because I think it's less important. But very important, the lateral hemispheres will give you a very prominent distal ataxia, and that's because this output from Purkinje cells to the dentate nucleus to VL thalamus and the contralateral motor cortex is impaired. Okay, and so again, the corticospinal tract doesn't get that necessary input to better regulate movement. Now, in terms of the cerebellar peduncles, the superior cerebellar peduncles is mainly output from the cerebellum to the motor cortex, and I mentioned one exception. There are others, but most important would be the ventral spinocerebellar tract, which does go in through the superior cerebellar peduncle. Middle cerebellar peduncle is easy because there's only one pathway that travels here, and that is an input pathway, the cortico-pontocerebellar tract. And when we do brain dissections, middle cerebellar peduncle is huge. It's the largest cerebellar peduncle, and it's just one pathway. It's all input. All right, the inferior cerebellar peduncle, remember 3 out of the 4 spinocerebellar tracts enter through the inferior cerebellar peduncle, but vestibular information from the medulla really goes back and forth, in and out through the inferior cerebellar peduncle. And then remember, we have the inferior olivary nucleus, these climbing fibers that enter the cerebellum through the inferior cerebellar peduncle. All right, the cerebellar cortex is very complicated, and I think there really are only 3 points, highlight points that I would take away from this. First of all, we have 3 main layers, a molecular layer, a granular layer, that's not so important really, and then we have in between here the Purkinje cell layer. So the 3 points, take-home points from the cerebellar cortex, first is climbing fibers, which come from the inferior olive, are very strong, positive glutamate stimulation of Purkinje cells. All right, so the inferior olive via climbing fibers activates Purkinje cells. Everything else coming into the cerebellum is via mossy fibers. So this could be spinocerebellar tract, could be corticopontocerebellar tract, vestibular information. It's all mossy fibers. And again, I wouldn't worry about the details. So a lot happens here to process this information, but once that is all said and done, all of the output from the cerebellum is via the Purkinje cells. And so this is inhibitory output that goes out to the deep cerebellar nuclei. Okay, and that is inhibitory. Okay, so those are 3 take-home points. Now this was just from the last lecture on the brainstem. We mentioned the central tegmental tract, and that if you have a lesion here, you get palatal myoclonus. That's the only important thing to remember. And also just that this is in the pons. But I just wanted to point out that there is a cerebellar circuit here, from the red nucleus to inferior olive, and from inferior olive to the cerebellum via the inferior cerebellar peduncle, and the dentate communicates with the red nucleus via the superior cerebellar peduncle. So we call that Mallory's triangle, but I'm really just bringing it up here to remind you again that a lesion of the central tegmental tract, you get palatal myoclonus. Let's go through some clinical syndromes here as we finish up. And so remember, when we look at CT, MRI scans, you want to imagine the patient's lying on their back, feet coming out toward you. So this is a left cerebellar hemorrhage. We can see some of the blood here in the fourth ventricle. And so because of the way the cerebellum is wired, the left cerebellar hemisphere is communicating with the right motor cortex. That means that ataxia is going to be ipsilateral with cerebellar lesions. So we get ipsilateral ataxia, and the cerebellum does communicate with these upper motor neuron pathways, and so we can have what's known as ipsilateral hypotonia, which is really rarely appreciated, but you may have some decreased tone from a cerebellar lesion, and that explains pendular reflexes. And so, for example, if someone has a left cerebellar hemorrhage or stroke, they're going to be ataxic on the left side, and because of the decreased tone, if you were just to tap on the patellar reflex, at least theoretically, the leg may just keep swinging back and forth longer than you're used to seeing it because of the decreased tone. All right, if we involve, if our stroke or hemorrhage involves more midline areas, flocculonodular lobe, then the patient will often have nystagmus. Dysdiadochokinesia refers to sort of a difficulty maintaining a regular rhythm. So, for example, someone with a left cerebellar stroke, if you ask them to tap the back of their hand on their knee and then the front of their palm and go back and forth, they can't do that in a regular rhythm. And action tremors, for example, in reaching out to an object, are very common with cerebellar strokes. Again, ipsilateral. Now, medulloblastoma is a common childhood tumor, about a quarter of all childhood intracranial tumors. And notice that we're on a sagittal MRI scan, and this tumor is very midline, which is important to understanding how this presents. Because if you have a midline tumor, then you're going to block flow of cerebrospinal fluid, and so these children develop hydrocephalus. And hydrocephalus will produce symptoms of increased intracranial pressure, headache, confusion, nausea, vomiting. Because it's midline, you're going to involve the flocculonodular lobe and the anterior lobe of the cerebellum, and so these children will have a lot of nystagmus and more of a truncal gait ataxia, much more so than a limb ataxia. Okay, and I think high yield for boards is to realize that these metastasize or seed via the cerebrospinal fluid, and so we can have these kind of drop metastatic lesions, especially that involve the spinal cord. All right, so chronic alcohol use. Here's a healthy cerebellum, and in alcoholism you have atrophy of the cerebellum that preferentially involves the anterior lobe and the vermis. So that means a patient with alcoholism will tend to have more of a truncal, wide-based gait ataxia, much more so than a distal limb ataxia. Wernickesencephalopathy, of course, is related to thiamine deficiency, and so these patients have a triad of an eye movement problem. It usually looks like a bilateral 6-nerve palsy, but it can take many different appearances. They're confused, as the name indicates, Wernickesencephalopathy, and if we have someone with untreated thiamine deficiency for weeks. This can worsen and they can go into a coma if it's not treated. And we get a gait ataxia, a truncal midline ataxia. So the story, who gets Wernickesencephalopathy? Well, it doesn't have to be alcoholic patients, although classically it is. And so these are patients that have borderline low thiamine levels, and when you give them IV glucose in a hospital setting, it dramatically brings out this triad. So I always think about this in someone who comes in, pretty healthy, they're coming in for knee surgery or back surgery, something like that. They're given IV glucose, and then all of a sudden they have a catastrophic worsening or new symptoms coming out. And again, here's the triad. So you want to be very primed. Don't give IV glucose without thiamine. All right, so why are they confused? Well, the mammillary bodies, which remember are part of Pape's circuit. And when we do an MRI scan in someone with Wernicke's, we see signal changes in the mammillary bodies. We can see them in other areas as well, but this would be high yield for boards to remember the mammillary bodies. All right, Friedreichs ataxia is a devastating condition that does involve a lot of the spinal cord. We can see here the posterior columns, the cortical spinal tract, but they have the name is ataxia, and this is our classic condition that involves the spinocerebellar tract. So way out here we have the dorsal and ventral spinocerebellar tracts, and these are significantly affected. So they have profound ataxia. And so onset is in childhood, so we shouldn't confuse this with B12 deficiency. They're both going to have a lot of vibration proprioception loss, but the childhood onset, the severe ataxia, should help you distinguish that. It's autosomal recessive, and this is the second trinucleotide repeat condition we've mentioned. So remember the first was myotonic dystrophy, and Friedreich's ataxia is a GAA trinucleotide repeat on chromosome 4. All right, so we have the spinal cord involved, posterior columns, cortical spinal tract, so they may have some upper motor neuron findings, and the spinocerebellar tracts, really all of them are affected. So the cerebellum doesn't get information about where the limbs are in space, and they also have peripheral neuropathy. So we can have a mixture of upper and lower motor neuron findings, and they may have a stocking glove sensory distribution as you'd expect with a peripheral neuropathy. So with so much of the nervous system involved, these patients typically worsen in a very steadily progressive manner. Some medications affect the cerebellum. I think the highest yield one to know is Phenytoin or Dilantin, and this occurs when blood levels become toxic. And this happens very easily, as I'll explain why later. So patients that are on this medication can suddenly complain of falling, and it's always important to look at eye movements in patients on Phenytoin. If they have nystagmus, then that would suggest they're getting too much Phenytoin. And then finally, a variety of perineoplastic conditions, especially ovarian, breast, and small cell lung cancer. Because of antigenic similarity, we can have antibodies against the Purkinje cells. And so this usually presents before the cancer is known. So patients are having ataxia, but again, if we've got a smoker, or you can't find out the etiology why someone has the ataxia, the progressive ataxia, then we should always search. We can do antibodies to test for these Purkinje cell antibodies, and then we'll search for cancer.